Yeah, go give and tell story, and I'm going to come off the podium. right, it'd be great if you moved up a little bit, and we'll get going and just hear a little bit from you about what the ahas were at your tables. I'll just give you a sec to get settled. Okay, you have a hall pass. Okay, so any ahas people want to share? Or things that had great meaning? Yes.
Oh my God, do we need a mic? Well, at our table we had a privilege to hear about sort of a development that is happening actually in my area in Fraser Health. And so I was very pleased to hear that there is really the opportunity to build or integrate services into the culture that is already a long-standing culture, and that's for me is the aha, to really bring the services into the culture and not the other way around.
Yeah, the back table had a lot of conversation about that as well. Other folks want to share anything?
I nominated myself the scribe, so do I need to use the mic?
Yeah, yes, you do.
Okay.
Because they're podcasting this.
I was with Petra on the table at the front, and some themes that came up, I think, were around an amazing leader in South Central and the power of that. Also, examples of the importance of partnership, and I really appreciated the advice that you were giving around that. Also, co-location came up, the importance of where you're locating services in the example. And I'm not sure who said this, but wouldn't it be nice to see greater consistency in our efforts across the province? Because a lot of us are doing somewhat similar work.
Great, and someone already touched on embedding culture and services and vice versa, and the importance of that. A couple of other points that we talked about at our table was just the incredible opportunities with the rise of the First Nations Health Authority and Health Canada stepping back, that there's going to be more flexibility in terms of how we approach services and the ability to be innovative. And of course, it wouldn't be a discussion if we didn't talk about non-insured health benefits. Lots of challenges there, but again, the potential to be innovative as we work with the First Nations Health Authority and the regional health authorities.
Great, thanks. So I'll just try to tell you a little bit of the story of the Oceanside Health Centre and the work we're doing in Island Health, and then leave some more time at the end for questions and more discussion. It was great to hear the conversations that you had. So this is a front door shot of our new Oceanside Health Centre that opened on June 24th. This is a pre-opening shot. I can still see the sawhorse. Clearly not as beautiful and culturally appropriate building as the primary care centre in Anchorage, but nevertheless, we're really pleased to have this resource in the community and within the health authority. So Oceanside is kind of the local coin name for the area of Parksville-Qualicum on Vancouver Island on the east coast. It also includes some more rural communities, Arrington-Coombs, where the goats are on the roof, and Hilliers, a more of a farming community. Has a population of about 49,000, but 500,000 visitors a year. The beaches in Parksville and Qualicum are very well known. Sandcastle competitions, internationally known, etc. It doesn't have a hospital. There are 3 hospitals within 30 to 45 minutes away, one in Comox, St. Joe's, West Coast General in Port Alberni, and Nanaimo Regional in Nanaimo, which is the biggest of the 3. It's a community that's wanted a hospital forever. So lots and lots of conversations about why don't we have a hospital, look at this community, look at that community, and you know the patchwork of acute care services over the province, history, tradition, etc. Today, if we're doing a planning exercise, it would look very different, but it's incredibly difficult to close a hospital in a community. So the population of Oceanside is older, and the older population is growing significantly. It's a real retirement community. The population tends to be healthier, although above average amounts of moderate chronic disease. There is certainly pockets of vulnerable populations. They tend to get missed in the population because the bulk of the population is older and well-educated, quite wealthy, and very organized. So we had an opportunity. So when we looked at what the gaps were in terms of some of the services, there really was a gap on the primary care side. There's a lot of people who are residents who do not have family doctors, or they've kept their family physician in Richmond or in Calgary or wherever because they knew they dare not give that up before they found one. And there was a real need for urgent care. So a lot of travel on the highway to Nanaimo, Comox, West Coast for mild, moderate, and of course appropriately severe levels of emergent care. So the world evolved as it does, and there was an opportunity within the Health Authority to create a health center. And we thought, we don't just want to build an urgent care center, we want a more comprehensive building. And this is it's starting about 5 years ago, some of this conversation. So the decision was, let's co-locate our community services in this building. And let's see if we can bring in the diagnostics, the lab, and imaging that were already in the community with private providers, and create a primary care center, have our own staff. We were thinking that we would actually have a private builder build it and run it. It turned out that it's VHA built and owned, which is great, because as our care model changed, it's so much easier to have the Health Authority in the driver's seat. So we opened our first services on June 24th of this year. So that was bringing in all our community services, most of our community services. We brought in home and community care, mental health and substance use, seniors mental health or the seniors outreach team, our integrated health network staff, our diabetes education staff. Our child, youth, family, public health staff did not move in because they'd had an opportunity that happened faster to have a new build with the school district and with Ministry for Children and Family Development. So they're co-located in a building called Family Place. So eventually we'll morph the reporting relationship of those staff into our geographic structure, but right now it's separate. We have a lab. It's a private lab, Life Labs. So they're they do blood draws and EKGs and things like that. And we bought the local radiology clinic. So we have a VHA-run medical imaging department. We have an urgent care, a medical daycare, and primary care. So the urgent care opened on September 16th with some of the medical daycare services. We're just ramping that up. And our primary care clinic with its first panel opened September 30th. So very little experience on that one yet. We wanted Oceanside. So as we went through our process of thinking about what integration might look like, we decided we had a great opportunity with co-locating all that staff to have Oceanside be our first demonstration of our integrated care model. And as we moved along, we've gone quite big and bold with our e-health strategy in Island Health, and we have an alliance agreement with Cerner, and we're actually creating electronic health records. So Oceanside is the demonstration of that movement to one record, one person, one record, one plan of health, which is our strategy. So we've been building the bridge as we walked on it, as the world changed around us and we saw other opportunities, and we didn't have a model. Normally when you build a building, you have the functional plan, you know what the service is going to look like, and you design a building around that. We had a building that was being built, and with a particular design, we were able to influence the primary care area, and we borrowed shamelessly from South Central and have the same kind of model with a collaborative center in the middle and then the rooms down either side, and we have a combination of exam rooms and talking rooms. In primary care, often you go to see your physician, lots of times you don't have to take your clothes off to get dealt with what you need to be dealt with, so that we have talking rooms, not just trying to make it more comfortable and more client focused. So we really wanted to accomplish all those things that South Central had done. Think about more long-term relationships, not episodic care, more client-driven, not provider-driven, team-based, not single professional-based, trying to deal with the whole person, not just one problem at a time. So this is what we had, and this slide's old. You can see it's November 17th, and because it's a picture, we couldn't change the text, but our current realities, we had all these services, our home care, mental health, diabetes education center, the acute care hospitals around, seniors health, integrated health networks, all in separate space around the building, all with separate intake processes and separate records. And the poor person seeking service trying to navigate that. And what we wanted was that model where there's one door, it's always the right door, and that the client is engaged and they're in the center with their family and informal supports, and the service is wrapped around and coordinated for that person. So we had two parallel processes going on. We had our regional work, which was trying to help us go from an emerging vision that we had when we came back from South Central to actually what a model would look like. So this is our, we've gone through several iterations of this and needed to respond to input from many of the partners and stakeholders we had. On your tables there was copies, and we have lots of extras, so Ian can pop those around. The full model. This is just the center. So you see we have the client or patient. We have a lot of debate what we can call the person. I think we should have the person, but the person, the family, informal supports in the center. The physician and team and the primary care provider could include a nurse practitioner is the next ring. The public health services, so those health protection, prevention, promotion services are the next ring, and the community infrastructure. So that's where we get at the context of the community, the culture, and the services of other services available, and really where we can influence determinants of health. So those three rings are wrapped around the person and their family at all times. And then the circles depict those episodic services. So when you have a need for a hospital service, it's episodic and you're in and out, but you're always grounded to your primary care team. So that longitudinal relationship over time. The same with other community health services or social services. Expanded primary care services, so there's a core team around everybody, but then you may need other parts, other home care or social service, mental health services. Housing and residential, another support that isn't for most people isn't over their lifetime, it's a period of time. And then specialty services or specialist services. So part of our journey with our community staff was really to have some conversations, and boy, some of them were really hard, about what is a comprehensive basket of primary care services. What of our community-based services really are primary care, and what are specialty? And let me tell you, the conversation about what's specialty and what isn't was hard, because everybody thought they were special. So we wanted, as we designed our model, and we'll come back to how we got to how we divided up those teams a little bit later. So of course, the client experience is paramount, so we started thinking about what do we want this to look like and feel like and be experienced like by the people we serve. And we had done the things that many of you have done, I'm sure. We'd done patient journey mapping and engaged patients and clients in that, and the stories and the circuitous routes you had to go to get somewhere, and how you had to, because we are siloed. That's a reality, that the conversation about your diabetes was different than the conversation about dementia, was different than the conversation about depression and anxiety. It was different than the conversation about the caregiver's anxiety. And we created what we called our wall of shame. The multiple referral forms that we had were all different, not just areas of not just home care, but within home care, there's a multitude of referral forms. So we looked at that. And the people we serve also told us really clearly that they only wanted to tell their story once. They wanted us to be good stewards of their information and make it easy for them to move through without having to start all over every time. So we pulled away from all our engagement that we wanted a single entry point for all services. Same-day service would be ideal. We wanted a blend of scheduled and unscheduled appointments. Warm handovers, so changing our language. So we don't internally in Oceanside, we don't refer to each other. So a home care nurse will not refer to the diabetes education clinician or to mental health. They huddle as a team and they do what we call warm handovers. We would refer out. So if a resident of Oceanside who was getting service from us at the center needed to have some specialty service in Victoria, that would be a referral. But within the center, we do warm handovers and we attempt to do full service at every appointment. So we took from learnings from South Central, and we've introduced 2 new roles. A clinical coordinator, and this is in primary care first, and we're emulating that in our community team, but we haven't got that all sorted out yet. So the clinical coordinator who manages that panel of patients or a group. So with the primary care team, they have a number of people that receive their family physician primary care services from them. We've got that clinical coordinator. We're just intrigued by South Central's role of behavioral health. I believe they called it clinician. We've changed it to consultant. So this is a master's prepared clinical counselor, addictions management specialties or training, who works with people around their behavior change. So again, getting at that, who's in control, and to make a difference in your health, you have to change a behavior. And it needs to be centered in what's important to you, so your goal of health, and why you would want to make a change. So the behavioral health consultant would work with people who wouldn't be eligible for our normal mental health and regular normal mental health and substance use services. They wouldn't have a diagnostic category that would make them eligible. So the behavioral health consultant looks at short-term interventions, mild, moderate anxiety, behavior change to support chronic disease management. The focus has shifted from programs and services to meeting the clients and their families' health needs. So we would have, in our previous iteration, the box that had all the different programs on the top, it would be, I'm a home care nurse and this is a service I can provide. I need to refer you to X, or you'll have to find, or worse, I'm a home care nurse and this is a service I provide, full stop. And the client and their family carry on. Services performed by integrated interdisciplinary teams, and so we had to go on a journey to figure out what those teams would look like, and that we knew we wanted some quick response to be able to support the needs of the clients, the people we served in urgent care and primary care. So to get to that max packing, you might come in with one thing, it's clear there's other things going on. How can we get you those supports at that visit, not I'm going to refer you to. It's all about attachment to primary care, because of course the principle is long-term relationship with a primary care provider is the core foundation, and everything drives from and back to primary care. So we're always looking to make sure that people are hooked up with a primary care provider, either in our center now that we have some capacity, or within the community, because there is a little bit of capacity out there. The client's electronic health record is a source of truth, and we talk about a health plan and health goals. We're not fully there yet. We're just starting on that journey. We have technology to enable us. We have a geographic focus, so we're actually structured in a reporting relationship. So everybody's peeled away from their old programs, and now they're part of a structure of Oceanside Health Services. And we have standardized processes and tools to improve consistency. So that is actually another lesson from South Central. What they said, they embrace variability if it adds value, but they found a lot of that actually having those standardized processes and tools that made it easy for people to follow the care path and to do the performance monitoring and the quality work was very helpful. So this may be familiar to many of you, the Kaiser complexity of need triangle, also used by Ministry of Health in their care management strategy. So we did, as we were thinking about our teams, we were thinking about how complex are the care needs, and we need to pay attention to all those levels. So the broadest level, level 1, is around a healthy population, and moving through to the pointy end is the most complex of the people we serve. And of course, there's gradation, and people move up and down. So thankfully, you're not in the, most people do not, we would hope they would not stay in that complex care area, but they do need special services when they have those needs, and then they would be supported to get back to primary care. We also thought about what really is an integrated care process, because we want one way in. There's one door. It's very easy to find, and however you get there, it will be the right door. We have one referral form now, not 47. So we did a lot of work with our team around getting comfortable with what an integrated care process would look like. And this is consistent throughout the building with small variations. So this is the primary care model, steps. And throughout, what the staff now understand is what they need to do at each step and who can do it. And that was a bit of a revelation, because most of our staff can do most parts. Again, that conversation about who's special. And what do they need to know to do that? So from just checking in that greeting, reception function, through gathering the appropriate data, doing the assessments, supporting, creating the first care plan, supporting self-management for those in primary care, optimizing the care plan, so that's really where you're focusing on the goals, and then transitioning the client out. So there's this same kind of care path exists in urgent care and medical day care, and with the community team upstairs. So our teams in primary care, this is actually mostly a new team. We have a physician, and the first physician in was one from the community, and that had always been our intent. And she has a small group of patients relative to most family practice. So she had about 600 patients. And so they've come over, most of them, a couple haven't, but they were consented and moved over with her to the Oceanside Health Center. We have a nurse practitioner as part of the team, the clinical coordinator role I talked about earlier, medical office assistant. It's actually a clinical office assistant is how we ended up framing it, because it's trying to get away from medical, and a scheduler, and then with access to the role of the behavioral consultant. So there'd be the warm handoff between the clinical coordinator, the family physician, the nurse practitioner, to the behavioral health consultant. And based on the NUCA model, one behavioral health consultant for 2 panels. So we only have the 1 panel now, and we're in the process of recruiting another physician. But meanwhile, we're intaking our new patients, starting giving priority to people who live in the Oceanside area who don't have a family physician at all. So as they're coming in, they're agreeing to be cared for by a team and to work with us in this new way. I should say also that the behavioral health consultant role was one of our former mental health staff role, when we actually looked at the staff, what the staff were doing and who they were serving. With our mental health and substance use staff, we identified that out of 17 FTEs, 3 actually were doing primary care work. Unfortunately, not all of them were qualified to fit the behavioral health consultant role, so we're working through that process, but that's where the folks came from. And the scheduler was one of our previous admin support staff. So when we moved from 5 buildings to 1, we had some efficiencies in terms of reception and intake. So integrated community care team, this is one of the biggest changes. So this is all our community staff that I described. Now one large team. We've divided them geographically just for efficiency, north and south. They're working in a whole different way through that integrated care process. We have created a role called an integrated service coordinator. So the referral that comes in is viewed by the service coordinator and assigned geographically to the appropriate team. The team huddles a couple of times a day and decides who the most appropriate clinician ought to be. So a referral doesn't come in and say, I need diabetes education. It describes the concerns the client has, and then the team determines the most appropriate way for them to be cared for. And they have access to specialty services who sit right there with them. It's actually an open area, broken up with modular furniture, and as in most open area concepts, folks are in the building, have an assigned workspace, others are floating. Lots of huddle space, collaboration space, phone booths for confidential calls, that kind of thing. So this was the hard conversation I referred to earlier. What's primary care, what's specialty? And we got to that actually. There are 3 key functions for our specialty services: knowledge transfer to primary care and the integrated community teams, consultation with primary care, and direct care for the most serious, complex, and unstable clients. So those at the pointy end of the complexity of need triangle. And again, moving, because everything flows from and drives back to primary care. That connection is never lost with primary care. And this is another way of describing it as we looked at when we might actually have our clients provided their care by a member of that specialty team, in this case, the mental health team, and how, as you move up, it's consultation and education, but the client themselves is staying linked to primary care, and that link never breaks. Again, very different from now. Primary care physicians would say, I send a referral to mental health at Island Health, and I never hear back. I don't know whether my patient was seen or not seen, but we're being very deliberative and intentional about always linking with the primary care physician. So we've got some key enablers, data, and again, we're not there yet. I live for the day that we have the data wall that South Central Foundation has, where they understand how well their teams are performing and what outcomes they're getting. We will be closer to be able to get there when we have one system, not a multitude of systems as we go with our new electronic health record. Technology to support, so of course telehealth, we're telehealth enabled, and linked, our urgent care is linked to the Nanaimo emergency department, so they can in real time do consultations and look at the medical imaging stuff. You know, was a public health nurse, so I don't have much of my clinical lingo left. And those standardized processes, which is one example, was that integrated care process and all the work in behind that. This is a big change management endeavor, and it's a struggle for some folks. So we do have very deliberate, again, in change management strategies through all of next year, and we have a real focus on evaluation. So we have engaged an external evaluator, a team from Dalhousie and UVic, and they're doing a very comprehensive evaluation. They're just finishing up the current state. They've done random mail-out surveys to the community members, and we've got incredible. 2 weeks ago, I had heard we were at 37% response rate, which is incredible. Maybe everyone wants to tell us we really should have a hospital, but I hope not. Also with physicians and staff in the community, kind of and clients that we serve, and then the evaluation will be over 2 years with a number of questions based on the triple aims. So, have we been able to improve population health? What's the client and the staff experience, and what about cost? Did we really need a building to do this or not? We've got some really incredible work that will happen. Of course, patient stories. So just a couple to share. So, and this is Meredith Saxon. Of course, I have her permission to tell her story and show her picture. So she was our first patient to arrive by ambulance to urgent care. She has a complex chronic disease and very frequent visits to Nanaimo Regional Hospital. So we were able to meet her care needs that day and get her ready to go, hooked, hand off back to our primary care physician. Some of the community team was able to make a follow-up plan with her, and she returned home with her husband and her in their vehicle that he had followed the ambulance. They were both thrilled. He was ecstatic and said, "This is so great. Now I'll be able to drive my daughter to work." So it's that whole family, client, and what has meaning to people. Another incredible thing that happened, and we were just actually quite kind of like hair on the back of your neck. So it was the Thursday before the August long weekend, and a gentleman walked into the clinic to the mental health drop-in. He had been living in a tent for over 10 years between Parksville and Qualicum in a wooded area. He had some mental health and substance use issues, but he'd also recently had a harsh diagnosis of pancreatic cancer. And he was in trouble. He was in pain, and he was lost. So in our normals, flashback, a home care nurse wouldn't visit a tent to do an assessment. There was lots of reasons, if we looked at our old model, that we would have had a very hard time putting together a service plan. The mental health clinician saw him in the walk-in clinic. He did have a family doctor. A contact was made. The fellow was welcoming some service. He knew he was in trouble and he was in a lot of pain. So the team huddled, and at first there was a little bit of, "Oh, we don't normally do this." No, client in the center, it's up to us to wrap around the services. So they made a plan. And even at 6 o'clock on the Friday night before a long weekend, in the summer, they're putting the plan together. By Saturday morning, he was in some housing that we knew about through our mental health program. We had the orders from the oncologist, so we could have his pain medication begun and pain management. And he was just ecstatic and relieved. And we just felt so proud of the team that they actually got their head around, we do things differently now. The other one that I'll talk about is max packing. So again, client into urgent care. He came in with a medical concern, but it was clear on triage that he had mental health concerns. So again, we have a walk-in clinic mental health clinician available during office hours. So that person was just brought right into urgent care after the medical needs were stabilized, and they began to manage the concerns of the day and a hard wired connection with the family physician. This is just our self-check-in, because we're the first in our health authority to just swipe your care card and you're checked in and it tells you where you go. Jimmy Pattison Center in Surrey has it, but it took a while to get to the island. And those are our fantastic volunteers. So what's the opportunity? Well, we think it's huge. Based on the learnings from South Central, we don't have any of our own health outcome data yet, but we're starting to hear some client satisfaction data, and also some staff. Some staff are still struggling. They miss the old way. And so what we're thinking about now is how we can spread that within the health authority. We have some great work going on in some other communities with partners, with divisions of family practice. So we're actually having a health authority conversation with our senior leaders on Friday about what's our spread capacity and how fast can we move forward. So I can't do Yoda. If Bob was here, he'd be doing this slide, but he's not here. So my summary is it's do or do not. There's no try. And we have an urgent need to transform our system. And there's some models and some learnings that we can take and move forward. So that's our intention within Island Health, and look forward to questions and more conversation. And we have about 7 more minutes. Yeah, there's 2 relatively small First Nations, Qualicum and, help me in with the correct, well, Nanoose, but correct, yeah. So they're relatively small. The Nanoose First Nation has a beautiful new health center. So we're having conversations right now about how one of our nurse practitioners can serve the communities, and also, of course, our community staff will outreaching. They're not just delivering service in the community. So we've had some conversations, and that needs to continue.
I know that we're getting a nurse practitioner now, and I'm loud enough without a mic. Oh. Anyway, well, I have a loud enough voice. I come from a clan that has women that can talk very loud. I lost my train of thought.
Nurse practitioner, you're talking about.
Yeah, we're getting our nurse practitioner, but our physicians actually come to the health center every so often as well to work within the health center itself. We're getting, there was a difficulty with the location on the new hospital on Hyde and Wye, but it's located in Queen Charlotte City, which is about 6 miles to 7 miles. I'm still on the miles, by the way, don't understand the flex. So it's kind of cool. I like the whole idea. One of the things that you said is you lost your clinical lingo. I wanted to mention that when it's client-centered or individual-centered or patient-centered, whatever you want to, the human being-centered is one of the things I like, is that clinical language doesn't cut it anyway.
Right. Very true.
What I'm finding with clinical language or any kind of language in the field, it's called a separating language. Nobody talks to one another because they don't understand what each other's saying. I was curious about the role of the behavioral change health consultant. At first, I could feel my knickers getting in a knot because most often it's us that has to change their behavior and not the individual that's sitting in the room with us. Behavior in the sense that we might be judging them.
Right. So the role would be to work with the client, the person that we're providing service to, around what their health goals are. So,
I
yeah,
wrapped around
yeah,
it after a while.
yeah,
because,
yeah.
I'm just trying to make a point. I guess I'm
You're
trying
very
to make
right.
a point with some of the language, although we use English and it's supposed to be this really great language to communicate with, everybody interprets it differently. So I was having a hard time quickly trying to wrap my head around that. I like that idea, by the way.
Great.
I'm not saying it's a bad idea. Other than that, I'm just grateful that there's humanness coming back into, a couple hundred years ago. My grandmother was a nurse. I mean, you talk about bridge. I know that I'm a bridge, and it's not exactly a fun place to be. My grandmother arrived in Skidegate in 1927, married a non-human being. She's Scottish, and I ain't about to part with that clan system either, right? So, but it was just like, and having to work within the community herself, like it's just, and going back, because she always went to the home. She always went and worked with the family. She was there during the big TB epidemic, losing whole families, fighting with the government for medication. So she actually used traditional medicine because it was available. I mean, she used the knowledge. It's just interesting, And so when I think about the time, what the whole profession, the helping profession was to start with, we seem to be stepping backward back into that place again, where it's all about the individual. What we have a way that in our language, and I lost it. I got little pieces, but we have a way. We call it holding the individual up. That's supporting, right? So I'm just excited. I'm blown away. And I think, and I'm sitting here thinking, I have Fraser Health here, I have Vancouver Island Health here, and I'm wondering, where is Northern Health?
At another session, I'm thinking.
Where is Northern Health Authority?
I was going to say, one of the things that I really appreciated about South Central is the focus on service and patient-centered. And I think that that's a message that we can carry forward and never forget about, because again, just learning about what the aspirations of the person is and how we can support them to meet their aspirations, I think is really critical.
All right, well, thank you so much. Sorry, Brennan, did you? Oh, sure, go for it. I didn't count long enough.
I just, thank you for your presentation. That's loud. I always appreciate hearing about experiences of people who've been and visited the South Central Foundation, and to know that Island Health is going down the path to implement some change that's reflective of our community's needs. And I'm really excited to hear about the electronic health record that you're using at the clinic or the health center. And I'm just wondering if there's been any discussion or thought about how the one record system might integrate or collaborate with the Aboriginal community electronic health records that are used on the island.
And I think, Brennan, there's been some high-level conversation and acknowledgement that there would be a value in that. Perhaps it's a conversation that needs to continue. So, and we're quite far from the electronic health record. That's probably a 3-year time frame, but at least we've made that commitment. So we're starting with pieces of it, with an ambulatory record in primary care that we can use across our system. So we need to keep talking about that. And we need to figure out how to get rid of all the old legacy systems too, right? Yes.
It's probably a very long conversation, but the big piece I got from the South Central experience is that they integrated services into culture, not the other way around, which often is token anyway. So can you speak a bit about that, please?
Well, I probably couldn't do it justice, but we definitely saw that, and it was one of those. One of their operating principles, as you saw on that list, was how important that was, and they are so intentional about checking themselves on on what decisions and how they make them. So, and the conversation we had at our back table at Little Buzz there was that had a lot of meaning for people, and we really struggle with that in our current reality. We kind of tack on, and we talk about cultural safety. Well, that's so far from where South Central is. So I think within First Nations Health Authority, there's an incredible opportunity to take that and go.
What initiative is Oceanside doing to move down that road?
We have not done a lot of work in that area. We have, but we do have our First Nations 2 communities engaged, and we're starting with what would it look like we have a resource, a nurse practitioner. So we're starting the conversation about, so what does that look like? As opposed to VHA saying, we have a nurse practitioner, would you like us to visit the health center Monday and Wednesday every second week? It's let's sit down and talk about what the needs are and how we could augment the gaps in service that you have in your community. So we're baby steps in this area, but we acknowledge that it's work we need to do.
Thank you. I just have one other quick question. Just looking at this Oceanside model and also hearing about projects that are happening in Fraser, where First Nations are partnering with their health authority. I'm just wondering if there's opportunities that you see on Vancouver Island for similar primary care centers to be established in partnership with communities.
Most definitely there are, and we have we're having different conversations about health centers and also integrated services, because you don't need a building to deliver integrated care. It really helps when services are co-located, because those conversations, those huddles can happen in the moment in the day. So we have some focused work going on in Cowichan and in Mount Waddington, and beginning in Tofino and in Cowichan and in Mount Waddington, the First Nations communities are engaged. So again, we're trying to go down the path together. So, and there's huge opportunities, as you know, based on our communities on the island. So it's lunchtime. I'm the one holding you back from lunch. So I just wanted to say very much thank you. I'm on the screen now, so thank you. My email was up there, but you'll get the presentation, so you'll be able to see that. We're happy to tell our story and have more conversations, look for opportunities to partner, and we are open for tours some days and not others, but we're happy to show off the center and show in real time the work that we're doing there. Thanks for your interest and for your time. Thank you very much. Heidka.
Good afternoon. Hi, if I could invite everyone in and take a seat. This is my third session today, and it's really been a great morning. And I've noticed that the attendees are really attentive. You just have to go, and they instantly focus. It's so nice. To not have to fight with the audience. So thank you all so much for being here today. I know that you could be at a number of different sessions, and this topic, actually I'm referring to the slide. I thought my first slide was going to be there. There it is. This topic is a good one for us to look at targeted populations. And just the idea of inclusion and the idea of diversity, I think, is something that we in health generally struggle with, but I think First Nations are really good at it. They're very good at including all populations and not being judgmental. Basically, First Nations people are, I think, very sophisticated. So I was really pleased when I was asked to address this issue, because I knew that there would be lots of interesting things for us to discuss here together. My presentation is about 20 slides, which I can go through fairly quickly, because I wanted to leave time for us to talk, for us to ask questions. And there are a number of people here who could have easily given this presentation, or who could easily share this stage with me. Because actually gay, lesbian, bisexual, transgendered health are actually 4 very large areas, and I'm really only an expert in one. As someone was saying, they only practice being gay on the weekends. and I only practice one of these. So not all 4 of them. So, no, I'm just kidding. What I meant to say, really, instead of making a joke, right, the sacrifice of a joke, is that really there could be a number of us here talking about these subjects. And thus, I would like to leave a lot of time for all of you to participate in a discussion and in comments, rather than me taking center stage for a really long time and putting me to sleep. Because really, this is, like I said, my third session. I really am getting tired of hearing myself. So, today's topic is lesbian, gay, bisexual, transgendered, and two-spirited health, braving equality in First Nations and Aboriginal health. And thus, we want to bring everyone with us in our quest for better health for First Nations in this province. So what does that look like? So this is, these are my youngest boys. They're twins, Jay and Quinn. Their moms, and my sisters. And I purposely included these because within my own family, there's been an evolving knowledge and acceptance of the different kinds of families that we can have. That certainly at the beginning, when I came out to my parents, and my parents, one of my parents went to residential school when she was 3, and she's very Christian, and thus she was very nervous about having a gay son. And my dad grew up in the bush with a very liberal First Nations culture from Slamon, where it wasn't Victorian or Christian based, and they weren't. My father wasn't sexophobic, so he had heard that men could be together. It wasn't a big deal. So at the beginning, when I came out to them, my mother was, well, she was puzzled. She really had no idea how 2 men could be together in that way. So my dad had to explain it to her. And for my dad, he said, "Oh yeah, I heard of that." I kind of thought it's not a big deal. But so we went from fairly good acceptance to them having an understanding that my relationships were equal to my sister's relationships, that my marriage was not second class to my sister's marriages. And what did that mean in the everyday? And what did that mean around children and families? So I just want to put this up as just one formation of what a queer or a gay lesbian family might look like. And for many of you, you know that we don't live just in a binary society. Many of us grow up thinking that we're supposed to learn to act in a particular way. And particularly for men, I think particularly for men, because we grew up in such a sexist environment, being feminine or being female-like or woman-like or girl-like is considered acting in an inferior fashion because of our sexism. So we're taught not to do it, when really, what's wrong with being a woman? What's wrong with a man acting in a more feminine fashion, and vice versa? When I was an actor in theater school, the women had a much easier time assuming male roles. It was more socially acceptable, or they could make that leap much more easily than the reverse. Men were much more phobic about taking on female roles. They had many more anxieties, many more issues. So this depiction, oh, is that your, that's funny. So the genderbread person just delineates for us our binariness around self-identification as female or woman versus male, and everything in between in that spectrum around gender queerness. The feminine, the masculine, and an androgynous or two-spirited position where we are both male and female, or we are neither. The idea of a biological sex and a genetic sex, and a phenotypical or a physical type as female or male or intersexed, and our sexual orientation or the object of our desire as being male or female or somewhere in between. And the idea of two-spiritedness is actually an old concept for us, but a new one as well, with a new twist, in that we can identify as two-spirited, or having the spirit of a man or woman in a single body, or that we are a continuum of both spirits in a single body, and that this two-spiritedness, this identity, is nested within a colonial context, in that two-spiritedness started to be a term that was used with gay, lesbian, bi, trans rights increasing post-Stonewall, at least in American, Canadian, Eurocentric society around gay, lesbian, bi, trans identities from about 50 years ago. However, traditionally, we have two-spirited roles, and very often two-spirited peoples were healers, they were medicine people, they were leaders, and just to use very common language, They could exist within a society as warriors or as caregivers or as parents or as your brothers and sisters and your aunts and uncles. They could live on the margins of society, maybe as cultural keepers, maybe as healers. Sometimes they were like second wives or second husbands who had sex with members of society, but they weren't at the center of society. And sometimes they existed outside of society. They were clearly banished from society. They lived completely away from everyone else because there wasn't a place for them in that particular community as a day-to-day person. They were someone you went to only in extraordinary circumstances. So the idea of how many of us there are or where we are is an interesting one. I think that the common belief is that 10% of us are queer. But if you do a survey, and here's one survey, a very famous life survey from the United States that identifies really about 3% of men self-identifying as gay and about 1.5% of women self-identifying as lesbian. But sexual activity is different again. Like men having same-sex behavior having sexual behavior with members of the same gender as being about 10%, and 5% of women reporting woman-to-woman sexual activity. It's very important for us to remember all of these ideas within the context of the First Nations and Aboriginal perspective on wellness. This model is one that was built over many, many, many months, even years, of consultation with you, First Nations healthcare workers in British Columbia, in that we have a very lofty view of health as a holistic issue, one where we can hold a lot of different ideas around health together at once. And so we can consider in the outer circle, for instance, our social well-being, our cultural well-being, our economic well-being, and our environmental well-being, even though we may only work in one of those areas, or maybe in none of those areas, or that we have only a strong understanding in a particular area, but not necessarily in another area, that the people that we have insisted on a holistic approach. So, for instance, if we're given a problem like, say, a pipeline, someone proposes a pipeline through our territory, we can use this model. Certainly we at the First Nations Health Authority must consider this model because we've officially adopted it, that we need to consider the health ramifications of a pipeline in all of these different areas. So a simplistic answer like we need a pipeline because we're poor and we need the money is an insufficient answer. We need to look at it with many different lenses and say, well, what about, community? What about culture? What about the future? What about the babies? We need to ask those questions in assessing any kind of health question. So in looking at Two-Spirited Health, today I would like to apply this particular holistic First Nations specific lens to discuss our health and well-being. So the First Nations Health Authority is a health and wellness partner. We have very strong principles of inclusion. We want better health for all First Nations, not just First Nations people that we like. And we have responsibility for our Two-Spirited members. Our commitment is to support health and wellness from the youngest to the oldest, remembering that a very large part of our population is young, and young people have a lot of sexual activity. We have a lot of evidence that young people are sexually active, and probably you have stories from your own families that your young people are sexually active. And when we look from our viewpoint as older people, that sometimes we don't talk about sexual health and sexual behaviors easily enough. This is a health indicator that we've been looking at for a long time. I've presented it many times before. This is around HIV-related mortality from 1993 until 2006. And the bottom line is HIV-related mortality for other British Columbians, and the top line is HIV-related mortality for First Nations. The line is a trend line. The actual numbers of deaths are the dots. And you can see in the light blue dots that there was an enormous drop in HIV-related mortality around 1997 with the introduction of highly active antiretroviral therapy. Literally a magic pill that changed HIV from a fatal illness to a chronic illness, and that changed people's lives from having a death sentence to that they could live with HIV, well, for as long as anyone else was living who didn't have HIV. And that this magic pill and the caregivers who gave this magic pill and its attendant care were changing health outcomes, and very few people suddenly were dying from HIV, at least in the non-Aboriginal population. So you see the dots, just bottom line there, and there are very few deaths. However, for us as First Nations, even in the presence of a magic bullet, that our HIV-related deaths continue to go up and up and up. And we wonder why this might be. I have some newer data. It will come up, and it brings up new issues again for us. Unfortunately, some bad news, but I'm just showing you this for now. So even in the presence of good care, even in the presence of a good care system, even in the presence of extraordinary health technology, literally down the street from us, Indians weren't getting it. We were still dying. And so this begs the question, maybe we know what to do to improve the health of our people. Maybe those services already exist, but it's not reaching us. The caregivers are not meeting with us, maybe. Those pills are not getting in our mouths, maybe. And so what are those obstacles? And these obstacles to care appear to be about our culture, who we are, where we live, and thus pertains to us as two-spirited people just because of the color of our skin. So issues like geographic isolation, and I'm sure that in your groups this morning, people were already asking, what about access? What about access in our rural community? What about access in our part of the province? Are you going to make it better? The issues of social isolation, that many of our community members are isolated from general community, whether that general community means the rest of our reserve or the rest of our Aboriginal community or the rest of greater society, but that social isolation, that feeling that we are apart from everyone else and we're not a part of their work or their services or their lives, is an important aspect for us to identify and knock out of the way. A lack of confidence in the system and in personnel, and what I did notice here, this gathering wisdom, is much more confidence in the system. That 5 years ago, we spent a lot more time saying the system doesn't work, you don't care about us, and this time, many more of us feel like we are part of the system, we can contribute to the system, and we have control of the system. And hopefully it's much, much clearer to you all that this is our system, and it's well within our power to transform that system so it helps more of us. Previous experience with our health systems can color how we think our current situation might proceed. That there are compelling distractions, certainly in the downtown east side, where there were a number of persons living with HIV who needed good care. They were distracted by some of the issues around them, including issues like homelessness, including issues like mental health and substance use issues. If you're a woman in the downtown east side, the danger of exploitation and oppression is extreme. Having worked down there for many years, women with addictions in the downtown east side have very powerful forces working against them to keep them where they are in exploited and disrespectful positions. That the social determinants of health are important for outcomes, that even if I could cure HIV or cancer, if I did that and threw you back in the street into your homeless situation where you were working as a sex worker, that I haven't done everything that I can within my power to give you a better quality of life. And so we must address those social determinants of health. Health literacy, this is an issue that was brought up time and again by our CEO, Joe Gallagher, yesterday afternoon. I know it was hard to hear him because he was time pressured, but he had a very strong message around health literacy, that our own health knowledge that we have collectively as a group, or that we have collectively within our communities, or that we have individually, does enable better outcomes. If we know how to help, then we do help. If we know how to live longer, then we do live longer. And the idea of knowledge as being a health protector and a health promoter is one that he conveys a lot, and one that we second as well. And so as physicians, we don't want to just keep looking at the ones who are already sick, but look to the idea of protecting health, protecting our own health. Issues of privacy keep us from seeking care. Historical institutional neglect. We can think that certain institutions are not going to help us. They're just going to treat us badly and give us yet another colonial experience. And part of my job is to reassure you that you can go to hospitals and physicians, say, and get the best care possible, that you should and can demand those. Stigmatization, we've spoken quite a lot about before, that if we keep painting a picture of ourselves as not being well, or as Dr. Shannon Waters was mentioning today, because her mother died younger, and because the health statistics say that Aboriginal women don't live as long as other women, that she can sublimate that idea that, oh, well, we just aren't going to live as long, and that she needs to work against that consciously to live a longer life. Microaggressions are the baloney that people keep throwing at us. Things like when I was at a hospital once, one of the caregivers said to me, "Oh, you guys get everything for free anyway, right?" Which made me furious, because I don't know what that means. That's really quite a ridiculous, lazy comment, but that kind of microaggression, or even sometimes overt aggression against us, can affect our care. Caregiver ignorance of our realities. I was part of a study looking at historical trauma in persons in the downtown east side, and in our intakes in the downtown east side clinically, we weren't asking patients if they'd been to residential school. And that meant that we didn't know about a very important factor in a person's mental health and well-being, and that was really an ignorance on our part, and that if you ask physicians, do you know what a residential school is? Do you know why you need to ask that of your clients? That needed to be addressed. Racism is alive and well, and I hope you're following the Brian Sinclair case in Manitoba. I was speaking to one of the First Nations medical health officers there, and I said to her, so was racism a factor in the fact that First Nations man didn't get care and was allowed to die in the emerge? She said, duh. Literally, she said, duh, to me. She said, of course there was racism in that emerge room, and that's why he was left to die and no one helped him. And there are probably other issues, other obstacles to care, but I just want to leave this topic for now and get back to factors affecting us specifically in two-spirited health. So this is a listing that comes from the American Public Health Association. I urge you to Google 2010 GLBT Health, 2010 GLBT Health, and a 500-page report on gay, lesbian, bi, trans health will come up. It's a very well-researched item, and it looks at these particular factors around these populations. So first is genetics. This is not a modifiable factor, so we don't spend a lot of time talking about it. Access to quality health services. Do we have culturally safe services where we can go, where we feel safe? Our environment. Our environment includes our physical environment and living conditions. And remember, this is not unique to gay, lesbian, bi, trans health. Our social environment. I think that if I was growing up here with all of you, I would feel really, really safe to be an openly gay man, and I am open to you and out. But in certain other social situations, people may not feel safe to be who they are. What is our work environment like? A number of gay, lesbian, bi, trans persons stay in the closet at work. It's not a safe place for them to talk about their particular personal lives, and this is unfortunate. And in our family situations, our families are our nests. Our families are places where we find love and support, where we're nurtured, where we find people to help us with the day-to-day, to financially support us. And if those families are rejecting, or if we don't have the same ability to have a family as others, this can affect our well-being. I wanted to make another point here on family. My husband's family was very rejecting when he came out, and he left South Africa to come to Canada where he would have more freedom. And I always felt really bad for him, and I thought, I wonder how many Aboriginal families are that rejecting, because I came from a very accepting situation, but certainly my family isn't necessarily like all Aboriginal families, that maybe some Aboriginal two-spirited people have had rejecting family experiences, and that would be really interesting to explore. And this is just my opinion, that I think generally we are much more accepting and less homophobic in Indian country, especially when we're more traditional than colonized. Educational and community-based programs can help with our health and well-being. For example, around homophobia, that we can be talking about families and family structures, about gay, lesbian, bi, trans health within the school system that can be helpful. Thank you. I have 6 kids, and I know that for them, it's been actually very easy to grow up with 2 dads, but it gets harder when they enter the school system and they have to talk about that situation with other kids, because those other kids may or may not have knowledge of that different kind of family structure. And so the problem is not within the home, but within the school system, where they start to get challenged by classmates who say, "What? You have 2 dads? How is that possible?" Health communication. Do we direct or target our health messaging to be inclusive? Where's Doug Kelly? He's not here. I was laughing yesterday to myself. Doug Kelly is not homophobic at all. In fact, he quite teases me, and he's totally cool with it. But yesterday he was saying, well, you know how you control a Coast Salish man with a Coast Salish woman? And I wanted to say, oh, no, wait. It's not a Coast Salish woman controlling me. It's a white South African. HIV/AIDS is the 14th leading cause of death for the total population of the U.S. and the leading cause of death for African American men 25 to 44 years old. Really unfortunate situation in the United States, and we know that HIV is an issue for heterosexual women of childbearing age in this province who are First Nations, but also for First Nations men who have sex with men. We'll come back to that. There are particular communicable diseases that may affect our populations, particularly sexually transmitted diseases that we should be able to speak freely and openly about. And cancers can affect gay, lesbian, bi, trans populations differently. These are our most recent results around new cases of HIV. You can see females in purple. You can see men in blue, and total is in gray. And this is from 2002 to 2011. The really important news here is that there is a decreasing trend to new cases of HIV for British Columbia. We are unique in the country, maybe even in the world, in that we have a decreasing trend to new cases of HIV. It is really quite extraordinary. We've had very good efforts here. And you see that our new cases of HIV are very, very low. The cases for men, though, the blue line, recently spiked, and they're still spiking. Our newest data from this year is that HIV infections amongst men are rebounding, and that downward trend is now back towards an upward trend, and that the majority of those cases are not heterosexual transmission for First Nations, but men who have sex with men. And so the outreach to First Nations, men who have sex with men, needs to continue, but we also need to be doing outreach to straight men who might be IV drug users or who might be getting it from heterosexual contact. So we need to have them both. Lesbian, gay, bi, trans health includes mental health, so we wouldn't be just looking at the bodies of two-spirited peoples, but their mental health as well, and their, some would say as well, their spiritual and emotional well-being. So the idea of teaching resilience is an important one. I was literally at a meeting where the presenter was talking about suicide and said, he gave these different scenarios on when should we intervene on this young adult who is suicidal. Should we intervene when they declare that they want to die? Should we intervene when they're holding the knife in their hand and threatening to commit suicide? Should we intervene post-first suicide attempt? And he even said, and if they escalate, like if they pick up something more violent like a gun, should we intervene faster? And of course, we are interested in mental health emergencies response, particularly as medical health officers in the new First Nations Health Authority. But lots and lots and lots and lots of people have said to us, don't you think you should respond sooner than when they're at the point of death? Don't you think your mental health services should support young people before they are seconds from death? And that, of course, makes perfect sense. And thus, the idea of resilience or mental health programs that keep our mental health strong is one that we need to bring to the fore. So I suggest that mental health services that protect mental health, youth programs that are around identity, around well-being, around flourishing, and maybe centered around activities that are not death-related, but maybe even something like basketball and fun are very legitimate and valid mental health programs that we should be promoting. Substance abuse is an issue in our population. It is slightly different in that the culture around drug misuse and drug abuse and drug dependency has a slightly different social skew than perhaps the general population, and thus we need to make inroads therein that can mean we give effective messaging and effective services when and where it's needed. Tobacco use is still an issue in our population as well. And because we don't have a gay, lesbian, bi, trans identifier at the province or anywhere else, I actually can't tell you if gays or lesbians, for instance, smoke more than the general population, drink more or less than the general population, or use or misuse drugs. I actually have no idea. And if we identify gay, lesbian, bi, trans populations as being important for us to target, maybe we need to search for some data on incidence and prevalence, basic incidence and prevalence. Physical activity. Physical activity for women is affected by their sense of safety doing those physical activities. Do they have places that are safe places for them to run, walk, camp, have regular physical activity? Ditto for gay, lesbian, bi, trans populations. They need safe spaces in order to have physical activity to promote and better their own health. And this may include gay, lesbian, bi, trans, safe physical activity venues. It may. It's just a suggestion, an idea, that a safe place for physical activity is one that we can afford to others. Body image and mental health, or feeling good about one's appearance, is a central idea, one that we don't talk about very easily, I think, generally. How do we, as gay men, perceive ourselves and perceive others? How do we, as lesbians, view our own bodies? How do we, as transgendered persons or as bisexual persons, view our own bodies, and how does that love or hate or everything in between about how we look affect our outlook on our health and well-being? And I just want to say that recently in a discussion, it wasn't recently, it's been more than a few years now, but really it's only been like 3 years at the most. I was talking to a minister of health about surgeries, about gender-based surgeries, and he said, "Are we in charge of this?" And I had to say, yes, we are concerned about the health of all British Columbians. Absolutely. So yes, we need to talk about who's going to pay for sex reassignment surgeries. So the idea of body image, bodies, mental health, and mental wellness are central concepts. We have a public health infrastructure, which includes health promotion, which includes health protection, which includes health planning, and health policy. And do all of these include two-spirited people? And I dare say, at this point, no, we don't apply that lens often enough. We don't think about planning for two-spirited populations enough. We don't think about health policy development for two-spirited people enough. We don't talk about health promotion in two-spirited populations enough. And we don't talk about health protection with that lens often enough. I've mentioned sexually transmitted infections. Violence is a large area in that some gay, lesbian, bi, trans organizations of late have been entirely focused on the idea of homophobia and bullying, that violence is a pervasive influence on the health and well-being of their young people. And so many of their efforts are anti-bullying, and many of their mental health efforts and their anti-suicide efforts are all about bullying. But violence is not just external. And the idea of violence coming in the form of bullying from another young person is not we can expand that concept to be a little more inclusive in that violence against two-spirited peoples can also come in the form of homicide. We know that there was a homophobic homicide on a First Nations reserve in the last 2 years here in this province. We know that domestic violence between intimate partners does occur, and are we talking about it and addressing it enough? And we know the concept of self-harm or suicide or suicidal behaviors, like suicide attempts, not just completed suicides, are alive and well, and are we doing enough to discuss this? For instance, recently the chief coroner issued a report after we, and I literally mean we, because I was on that panel, when we looked at suicide in young people, one of our recommendations was we need to find a way to ask if this young person who's died was gay, lesbian, bi, trans, self-identified. And was that a part of their decision to take their own life? And is this something that we can ask, or how do we ask this so that the family feels safe in talking about that possibility? You can imagine how delicate a situation that is to ask if this young person who has just passed away had gay, lesbian, bi, trans identified issues, and that if that played a part. Because we suspect that a significant proportion of youth suicides are related to their two-spirited identity. Homophobia, ignorance, fear, still out there, still making it a bit difficult. I'm trying to think of a homophobic situation I've had recently. I have such a privileged position in that I don't get a lot of sass, except here in the front row. I don't get sassed a lot about being gay. So I don't have a story, but maybe when we open up the floor, those of you out here can share some stories about homophobic situations that are instructive to us about how we might help. And this is an issue about what I've just described around the chief coroner, suggesting that we ask around gay, lesbian, bi, trans, queer identities and two-spirited identities in our follow-up. Here's a very important document from the Institute of Medicine, and it looks at issues of disparity within the health system. These are disparities that are these are health disparities that come from the system itself, not from the patient's behavior, say, where we see bias and stereotyping affecting caregivers, affecting how they care for us, and that widen disparities and challenge our equality and our equity. We as two-spirited people also wish for culturally safe environments where I can say my husband without someone falling off a chair. And I did have someone recently almost fall off their chair when I said my husband, and they said, what? And I said, my husband? And they said, did you just say your husband? And I said, yeah, my husband, a man. Because I think they thought that I was ESL or that I didn't quite have the terminology right. And they said, yeah, my husband, a man. So diversity, it's in all of us. I don't think there's a straight, white, middle-class, heterosexual male exclusively in this crowd. We're all different and diverse in some way, and that equal opportunity for all of us, not just a certain few of us, is what's moral and right. Imot, thank you. Here's my husband and some of my kids. So let's thank you. Let's throw the. Right. Okay. So is there a roving mic? Can we take one question? One comment? Oh my gosh, I totally lost control. Yeah, we have 5 minutes. My apologies. Anyone want to comment?
I want to thank you, Evan, for having this, because this is something I've been asking for a long time, to have this addressed. I'm the parent of a transgendered daughter, and when my daughter decided to come out, of course I knew that she was gay since she was very little. And I was blamed for that. It was my fault. And I had to witness a lot of bullying from her friends and family because they wanted to make her into a little boy. And it was really tough to see that. And I was victimized to that. So I've been really advocating for a lot of this, to come out, let's talk about this. Let's share. Let's take down the fears, the barriers. And I really hold my hands up for you to do this, because
Thank you.
it takes courage. And I really want everyone to take some of that courage for yourselves, to be able to share. I love what Don Burnstick said the other night. He said that there was 4 lessons he was taught to wellness. And unfortunately, I only remember 3 of them, because he kind of went through them so quickly. And one of the first things was sharing, so that you could cry. And I thought that was so wonderful. I loved those words, because this has been such a deep, dark secret for so long. And we've got enough secrets. We've got enough pain to deal with. These are our beautiful young people. I would just really hold my hands up to everybody if you could take some courage now today to be able to openly talk about these for yourself and for your communities, for your friends. It's getting easier. I love that they're in the media and television, there's a lot of talk about gay friends, and a lot of the younger people, to me anyway, are so much more accepting than people in my generation. But I know it's still hard out there. I still hear a lot of moms having to go through what I did, saying, it's your fault. And those kind of things don't need to happen anymore. So thank you I'm really thrilled to see so many people here.
Yes.
I really am. Thank you.
Thank you so much, and I'm going to leave it there, and I hope that you see yourselves and your beautiful young people in this plan. Thanks very much. Good afternoon.
Big thanks to Evan, that was really great. Coming up in just a few minutes, we are going to have Dr. Nadine Caron from the UBC Centre for Excellence in Indigenous Health talking to us about some of the initiatives that are happening with the centre. So feel free to check that out.